Welcome back, everybody. In this lecture, we're going to be looking a little bit closer at the new branch of psychology that we introduced in our very last lecture. In particular, we're going to be trying to define what clinical psychology is all about today. We've obviously looked at some past perspectives on the field and sort of gone through the evolution of how we got to sort of where we are in clinical psychology today. But we're going to get a little bit more detailed in that exploration of what clinical psychology is all about and some of the different career paths and tools that are used by today's clinical psychologists. To understand how we got to where we are in this lecture, I do want to spend just a minute or two reviewing some of the topics we covered in the last lecture. If you remember back to our history of clinical psychology / abnormal psychology lecture, you probably remember the work of a very famous person in our history of clinical psychology named Philippe Pinel. He was the one in charge of the Parisian hospital systems in the late 1700s, and he was the one that pushed for the release of many what were called mentally ill patients in these Parisian hospitals. He tried to also oversee the change in approaches to how to handle individuals with mental health issues and how to perceive them in a different way. Now, Pinel's work to this day is celebrated as a groundbreaking idea, but it took almost a century for many individuals to really fully embrace the work of Pinel. And to be fair, it actually took the work of our most controversial individual, Sigmund Freud, to shift a lot of people's perspectives on mental health in terms of its causes and some of the things that can be done to help individuals. Since we've gone from Freud to our current takes on clinical psychology, a lot of new ideas and models of mental health have started to pop up. And these models really reflect the revolution in thinking that we've undergone in the clinical psychology realm. One of the models you might hear a lot about if you do start to pursue things in clinical psychology is something called the biopsychosocial model of mental health. It suggests that many of what are considered abnormal thoughts or behaviors are a byproduct of the interaction between these three critical components. Our biological world, which is both the cellular activity and structural activity of our nervous system, psychological factors, which are the mental workings of our brain, either the thoughts we have, the emotions we experience, or just the ways our mind is designed to interpret the world around us, and the social factors, the stressors we're encountering, the situations we're being put in, and some of the cues that we're being given, either at the time or as we're sort of growing up and experiencing different things. What many of today's clinical psychologists will attempt to do is understand a person through the combination of all three of these components that we think are really big, important issues to address in trying to help somebody with a multitude of different clinical problems. This model is also paired sometimes with something called the diathesis stress approach, which attempts to try to understand why specific types of mental health issues arise in specific people, insinuating that there's a combination for almost everybody of some biological predisposition for developing a certain type of mental health issue and stressors or social factors that lead to the eventual emergence of whatever somebody might have an inclination to develop in the first place. Now, these models and ideas might, to this day, not seem extremely rare and novel, and in fact are almost intuitive. But if you go back about 150 years ago, it would not be the case, and many people would actually contend that mental health problems and other things were really a byproduct of other issues. But as we've evolved in our thinking, we've also evolved in the profession as a whole, to where clinical psychology today is very different from what it was just about 100 years ago. In today's clinical psychology, most people finding themselves in this profession tend to focus their attention on the abnormal, or what's sometimes called the atypical. Now, what defines atypical or abnormal is sometimes difficult. Historically, the thing that was defined as abnormal was something that was usually considered within a culture socially deviant. What this implies is that people who need help are those that are doing something that doesn't quite fit with the society or the group that they're a part of. There's a lot of intuitive benefit to this kind of definition of what constitutes something a clinical psychologist could look at. For those who are not adapting to their environment in a way that's considered maybe normal, we can see a need maybe to help these individuals. But many clinical psychologists over the years have started to contend that even though this might be a starting point for some assessments of clinical health issues, it's not necessarily a definitive definition of all individuals who might seek out help or individuals that people within the profession of clinical psychology could look at. Another concept that started to pop up over the years was this notion of statistical deviance, where people's behaviors or thought patterns were not just undesirable within a culture, but really far from the average. And when we talk about statistical deviance, we can start to talk about how it's not just about people displaying thoughts or behaviors that aren't necessarily desired, as much as it's now people displaying thoughts or behaviors that are significantly different from the norm. Now, what constitutes significant is something that we can debate, and in fact, if you get into clinical psychology and start learning about the percentages of people afflicted with different mental health issues, you might really question what it means to be statistically deviant when there are so many common disorders out there. But this definition of looking at individuals who are statistically deviant adds another wrinkle to the definition of things that clinical psychologists or people that call themselves clinical psychologists can look at. Another thing that tends to pop up in the definitions of what constitutes something a clinical psychologist could look at is this idea of something called maladaptiveness, an inability to function within a society or within a group in a way that's considered maybe healthy or beneficial to both the individual, the group, or society that these people are a part of. And there's always a lot of gray zones within these terms and concepts, but most people who study clinical psychology do tend to look at individuals on usually the lower end of these areas, even though it's probably important to note that some current clinical psychologists are actually turning their attention to the other end, the statistically deviant on maybe the desirable sides, to try to understand where these things are coming from and how these things manifested themselves within these individuals over time. This also brings us to another important component to many individuals in clinical psychology, and it's something we call psychopathology. An exploration into the environmental factors, the brain and cellular structural issues, and also the mental, psychological components that are the sources of a lot of mental health issues. When clinical psychologists try to help individuals with specific problems, they also typically ask where these issues are coming from. And to be trained in the field of clinical psychology, you not only have to know how to define things, but to try to explore where certain things are coming from. And we're going to learn in our next lecture about a multitude of different perspectives of how to address where things are coming from and ideas of how to help individuals when they get into specific categories. But I want you to just be familiar with some of the ideas that are kind of constant within clinical psychology, even if people take different perspectives of how to address these specific ideas. Another thing I want you to be aware of through this lecture is that not only are there lots of different perspectives in clinical psychology about which techniques and ideas most effectively explain different mental health issues, but there's also lots of different types of professions within the area. Many incoming freshmen in intro classes tend to think that clinical psychology is just all about helping people. And to an extent, there are many individuals within clinical psychology that do get into some type of counseling or therapeutic work. But there's also lots of individuals that go into clinical psychology that don't specialize in this broad overarching approach. Some individuals focus their attention on things like family structures or school psychology or a specific type of disorder that they really want to help individuals with. Others spend their time learning a lot when going through their degrees, learning about assessment, how to define specific types of mental health issues or specific types of developmental issues that can allow other clinical psychologists to help individuals once these things have been determined. There's also another collection of individuals who go into clinical work that focus their attention on biological structures, either structures within cells, structures within the brain, or the chemical components that are impacted by clinical ideas. Many doctors who get into psychology-related professions do it through something called psychiatry, where they learn not only some of the different clinical ideas that we'll be talking about in the future classes, but about medicine and how it can play a critical role in a lot of different mental health problems that people struggle with. And on top of all of these types of things that people in clinical psychology can pursue, there's also another branch of individuals within clinical psychology that don't spend a lot of time in a clinic talking with specific individuals. Instead, they might be interested in researching things like stigma associated with different mental health issues or different designs of cultures or environments that might help people with different problems. Not necessarily to specifically help one individual, but to help large collections of individuals once we understand specific clinical topics a little bit better. There are also individuals who engage in something called experimental psychopathology, where they look at not the overt differences between individuals defined with a specific mental health issue and those that are not, and instead they look at other related components that could be playing a role in some of the mental health challenges people are struggling with. For example, one might look at memory differences between those diagnosed with schizophrenia and those who are not, or look at eye tracking abilities of people struggling with depression and those who haven't had any indications that they have those issues. Not necessarily to say that those things are causing some of these mental health issues, but to maybe explore other avenues that need to be addressed in both the assessment and treatment of individuals with a multitude of mental health problems. There are also many who pursue things related to psychiatry where they try to understand different mechanisms within the brain, within the body, that could be altered or be actually fixed to help individuals with a multitude of different problems. All of these things, again, highlight the variety of different professions that people in clinical psychology can pursue, even though they all tend to call themselves clinical psychologists in one way or another. And this brings me to a really important thing that I really want to highlight when people learn about clinical psychology. As we progress, I'm going to warn you numerous times, and as we're going over different therapeutic techniques and different types of diagnoses, that just learning about these things on the surface is not sufficient to think of yourself as a clinical psychologist. It's because anybody who calls themselves a clinical psychologist has gone through at least 6 years of training, oftentimes significantly more, to gain that title. For somebody to get into a degree in clinical psychology, they first have to earn their bachelor's, usually specializing in clinical psychology topics by taking multiple clinical classes offered by their schools. And then they have to go on and earn at least a master's degree or beyond. In fact, most people nowadays, if they do want to get into clinical psychology, tend to take right off the bat the doctorate route. Some doctorate routes can last all to 7 years, well, or more if you take a year or two off. And along the way, you could potentially earn a master's degree, but it's not necessarily a critical thing because a lot of the professions people are pursuing these days require a doctor's degree and then at least a year or two afterward of training and licensure studying so somebody can really prove that they are well versed in the specific area that they choose to pursue. Some of you might be sitting there right now wondering, What on earth would be required for me to be at school for almost 10 years after I finished my undergraduate degree? What am I learning along the way? Well, not only are people in clinical psychology learning about the multiple nuances to clinical psychology that exist, some of which we'll again scratch the surface on in the next couple lectures, but they're also developing specific skills and techniques and all updating themselves on all the new trends and approaches that are constantly being worked on within the field. They're also, as they're going through this, developing their research skills, learning how to not only study specific topics, but to be better assessors of the research that other individuals are doing, to be able to think critically about how somebody approached something and whether or not there's anything else to consider or any shortcomings from the work that they're digesting as they're going through their doctoral training, and constantly keeping themselves updated on all the new things that have been explored by clinical psychologists. This brings us to one last thing that you're doing in these years, and that's you're developing tools. Not just techniques to be a therapist, but specific tools that can help you with either your biological approach or some of the other types of things that you can get into within the field. What are these tools that we have? Well, some of the tools could involve things like learning to assess people better, or learning how to put people into specific categories better. How do we do that? How do we assess and categorize individuals? Well, this is something that we actually went through quite a growth in over the last 100 years. Historically, when clinical psychology started to become a profession, and people like Freud and some of the people we'll talk about in future classes started to try to find their ways of defining what problems people had and how to help them, a lot of these therapists or clinicians, or we could just call them theorists, tried to come up with their own tools and definitions for how to kind of best categorize individuals with mental health issues. These tools and these definitions did allow individuals within these areas to communicate with each other better and assess whether or not some of the new techniques they were developing were working. But it created a lot of issues when it came to being able to communicate about topics effectively across different approaches and to assess the utility of different approaches in a scientific way, much like all the other branches of psychology were doing at the time. And it created this need in the 1940s and 50s as psychology started to grow to find kind of a universal mechanism that people could use to not necessarily help individuals in clinical psychology, but just define some of the things that people were struggling with. And this eventually led to the development of something that's still in circulation today called the Diagnostic and Statistical Manual of Mental Disorders. Often you'll just hear referred to as the DSM. Its first edition was published in 1952, and its goal was at that time the same goal as it is today, to just define not only different clinical issues, but terms that relate to clinical health, so all people within the field could essentially speak the same language. Again, it wasn't an attempt to try to push everybody within the field to use specific techniques. Most people tend to call the DSM, even though there's differing opinions as to some of the things that the DSM looks at, as to whether it's truly this, but most people try to call the DSM atheoretical, which means it's not trying to convince individuals that if you want to be a good scientist, you need to use, say, the humanistic approach or the cognitive behavioral approach, things that we'll be talking about in our next lecture. It just tries to look at the different societal, social, mental, and structural things that are potentially at play in lots of mental health issues and gives people kind of a manual that they can use to categorize some of the challenges that people are going through. And it's something that, since it is trying to adjust with time, constantly being revised. Or currently, since 2013, in the 5th edition of the DSM. There are talks about coming up with a new edition eventually. Right now, we're just in different iterations, different versions of that 5th edition that started to be published in 2013. And this is also true for another manual that's used outside of the United States called the International Classification of Diseases, or the ICD. Now, the DSM within the United States is focused primarily on mental health issues. The ICD goes well beyond mental health issues. It looks at a multitude of different health struggles that people could potentially have, and it's something that is attempting to go across multiple cultures because it is something that's used by the World Health Organization. There are some clinicians in the United States that do use the ICD, but for the most part, if somebody's learning about clinical psychology, they're not only learning about their specific techniques, some of the tools that they need to develop for their own specific profession, but they're also spending a considerable amount of time learning about the DSM, how it's organized, some of the critical components to it, and how to reference things when they're helping individuals with whatever thing that they're specializing while they're training and getting into the clinical field. And this brings me to another really important point that we want to consider when talking about the tools that clinicians are developing. Even though we just talked about the fact that in the United States, most individuals in clinical psychology will learn about the DSM, it doesn't mean that it's a universally accepted tool and everything else is more up to interpretation. Even though it's celebrated as a very important thing, there has been, even since the 1950s, a lot of pushback to the nuances of the DSM. One of the biggest issues that people have with this is that it does create this dichotomy of somebody who's healthy or not, and whether or not somebody has a specific mental health issue or not. Many people within the profession have contended that this attempt to mark somebody as healthy or not creates not only lots of problems within definitions in the field, but with individuals who are being categorized. There's lots of research in recent years that's focused on the stigma associated with the diagnosis of different mental health issues and with the kind of categorization of people into one grouping versus another. What exacerbates this problem for many clinical psychologists is that not only is it sometimes challenged to figure out where the cutoffs are, but even with cutoffs, there's lots of what we call imperfect sets or imperfect nestings for numerous mental health issues. We're going to, in a couple of classes, talk about a specific disorder called depression that is extremely multifaceted, with lots of different symptoms being traced back to a diagnosis of having depression. And what we'll cover when discussing this is the fact that there aren't any specific symptoms that are required to reach a diagnosis. You just have to get past a certain number, to at least a certain threshold of symptoms, to be diagnosed with this disorder. And this sort of makes sense in a clinical realm and a definition realm, but if you think about it as a whole, you might start to wonder, are these definitions, are these requirements, are these categorizations the perfect thing, or just terms that we have developed to be able to communicate about these things a little bit better? And coincidentally, if these things are just things we've sort of come up with on our own, how can we be okay with some of the things that come with the diagnoses that people are given from these arbitrary requirements? How can we be okay with people being lumped together where maybe there's other factors that need to be considered and they're maybe not struggling with the same thing even if their symptoms look somewhat similar or put them in the same category? How can we be okay with the struggles that many people face when they do reach a certain threshold or maybe don't reach a certain threshold for a specific disorder, even though it might be close to having those issues that qualify them? And another thing that becomes an issue with the DSM is its design is specifically set up to sort of go beyond the situational and mental components that we just talked about at the beginning of this lecture. We know that there's lots of reasons for mental health issues to pop up within individuals, and it's usually a combination of things that are required for people to develop some of the problems that lead them to the clinical field. But the DSM is not designed very well to look at those factors and weigh them in a rational way. It sort of makes sense that it struggles with that because it really is just supposed to be a manual, not somebody who's doing something to make sense of individual, but it does create some instability issues when we look at how somebody can be clinically diagnosed with things and what can be considered from clinician to clinician when somebody is being examined through this tool. And another thing that pops up with a lot of these disorders and issues is that, again, since these things are sort of arbitrary, disorders can come and go, and groupings can come and go as time passes. The typical example that's usually cited in a Psych 1 class is the fact that homosexuality was actually considered a mental health issue in the first edition of the DSM. And it wasn't until several revisions that was actually removed as a clinical diagnosis. It seems odd to think that somebody could be sent to a clinician and they could try to fix that person because they had a mental health issue just because they were interested in somebody of the same sex. But for a long time, well, not a long time, but for a time, this was a component to the DSM. We've had numerous things like this pop up over the years, sometimes a byproduct of the society at the time, other times a byproduct of kind of situational factors that need to be considered. A great example of this, if we're looking at situational factors, is something that actually just happened in the most recent edition of the DSM, where there was a whole classification of disorders that were merged into one, in particular into something that's now called autism spectral disorder. Prior to that, there were different types of mental health issues that had some similarities to them that were considered distinct. There was something called Asperger's syndrome, something called autism, and others that sort of fit into this category that had their own unique definitions or at least terminology tied to them. But in the newest edition of the DSM, all of these different types of, well, what used to be different types of disorders were collapsed into one. Not necessarily because researchers concluded that they were the exact same thing. They concluded that due to some of the situational constraints tied to it and the gray zones and governments and insurance companies not covering certain things related to it, even when they were similar, it would be best to collapse all of these different categories into one, and knowing that they would upset people, but theoretically help more in this process. It's not saying that that decision to collapse all of these mental health issues into one category was necessarily wrong. It just highlights how situational factors are still critical players in the DSM, despite the fact that it's treated as sort of an absolute manual by many within the field. And one last thing that's important to note is that this is a very exhaustive manual, so large, with so many mental health issues embedded within it, that many individuals who are struggling tend to leave a clinical intake with at least one diagnosis of a mental disorder or some type of mental health issue that merits being examined. Now, it's probably fair to assess that many of us should probably talk to a clinical psychologist every now and then, even if we don't necessarily have a diagnosable disorder. But to infer that about 50% of our population is in desperate need of mental health is probably a little bit of an over-exaggeration. And this oversensitivity of the DSM is something that has been considered in lots of debates about the utility and the functionality of this specific manual. With all of those things being said, it's pretty important to note that this DSM, with all its problems and shortcomings, is still considered by many in the clinical field to be a really critical tool that allows clinical psychologists of multiple perspectives to communicate with each other effectively and to save a lot of time and hassle that was around when clinical psychology was starting to develop and this tool was not around. Many people who go into clinical psychology can bank on this notion that they will learn a lot about the DSM and recognize that there will be continual revisions, updating and altering how clinical psychology is approached and how things are categorized as this field continues to evolve. And the nice thing is that hopefully with this adaptability of it, some of these issues that we've talked about before can become less and less problematic as this tool adjusts to all the different things that researchers and clinical psychologists are finding with respect to this field. And this brings us to, hopefully, a good stopping point on these topics. Obviously, there's a lot more to explore within clinical psychology. We still got more to do, but I think we've covered a lot of the critical things that I wanted you to get from this lecture. What clinical psychology looks like today, what types of careers are in clinical psychology, some of the tools that clinical psychologists learn about. In our next lecture, we're going to turn our attention to some of the techniques that clinical psychologists learn about and how those things reflect some of the perspectives in clinical psych that are still there today that really do differ from profession to profession. So hopefully you got a lot from this. Hopefully you're all hanging in there. And I'll bid you all adieu. So I hope to see you soon. Take care, everybody.